Thank you, Ingvild. Okay, so we have about 45 minutes. I'm going to go ahead and take the moderator's prerogative to ask the first question, and then we have a bunch of folks that are lining up. So first, for Richard, can you delve in a little bit more to the issue of payment change, global payment delivery system reform, and specifically how metrics play in, how paying for metrics play in, and what's available to us in the area of metrics tied to medication. And connected to that, is there the opportunity for flexibility to bring in new reimbursed services like peer navigation? And then the second part of my question goes to Katrina, which is, can you say a little bit more about what the role of peer navigation is, what it looks like, what it involves, and how it connects to use of medication? Thank you both. Yeah, thank you.
Hello? Okay. I'm just sort of raw here. So as it pertains, I know there's models all over the country, but as it pertains to the research study we're in, we are trying to demonstrate that those folks that are returning citizens from incarceration that are met with somebody in the community like myself that have a shared lived experience, if they're connected to health supports and recovery supports, housing first, of course, so housing, transportation, employment, et cetera, and then having that peer mentorship, but above all, health support, right? So the navigation, as they mentioned earlier, of the system for, to even get Suboxone or methadone is maddening. I mean, folks can't even begin to figure it out. So our role is basically, from the moment they're out, is to work as sort of like a hybrid AA kind of model, Alcoholics Anonymous type sponsor, / navigation. We're directing them to existing supports in the community, or if there aren't these resources, to identify those gaps, report them back so that we can begin to do that. And as it pertains to Suboxone, above all for me, that's my first priority is getting them, whether it's Suboxone or methadone, getting them directed immediately to that. And of course also the recovery or the counseling and programs and things like that to supplement or to complement that. Yeah, thank you.
So I think there are a lot of ways where you can pay, I think, successfully. Right now we're in the middle of a big experiment. Medicare is doing sort of a global budget type of thing through their ACO programs. Several state Medicaid programs around the country, including Massachusetts, are doing it that way. The track record so far on mental health and addiction is not good. And I think the reason for that goes to the second part of your question, which also goes back to the last session, which is, what do you want to buy? What are you paying for? And I think that our performance metrics that we use as part of the sort of integrated measure set that's used for ACOs, for Medicare Advantage, for many of the NCQA places, are really incredibly inadequate for mental health and addictions. And so we just need to do better. We need to target things where there's a problem. I think there are some very practical, and I think if you do that, the more you have good performance measures, the less it matters which of these types of payment systems you deal with, because you're holding people's feet to the fire when they're carrying risk. And so the ASAM thing, although my friendly amendment to ASAM is you pay to get people in as well as doing the other things. But I think a targeted approach like that can work, and if you don't have an ACO type of world, that's probably a good way to go. If you have ACOs naturally occurring in your state, then I think doing the performance measures alone and holding people's feet to the fire could be important. Now, what those measures are, you know, there's an industry out there where people are in the business of producing those measures. I would start with like a bunch of, if you think the biggest problems are people don't get treatment of any kind, if they do get treatment, they're unlikely to get the good stuff, and then they're unlikely to keep getting the good stuff. 3 measures that sort of capture that would be where I would start.
Thank you. Chinazo, and then Scott, and then David.
So just a comment to Katrina. As a primary care provider who's been doing this for 20 years, I'm heartbroken by hearing the story. We just have so much work to do. Also, I'm going to show a little bit of my ignorance here, which is crazy because I've been doing this for 20 years. I don't actually understand exactly how treatment is funded in this country. So I hear Medicaid expansion, and I hear about Medicaid not covering methadone. But I also know there are these federal block grants. So we're paying for treatment that was structured in 50 years ago. Who's paying for? I'm sorry, like who's paying for that? and you know, I mean, what are your recommendations about how to restructure payment? Should these block grants stay with and then having performance measures? Should we? I mean, should this be Medicaid? Should this be Medicaid? I mean, I'm just so I need a little bit more information.
So I guess in the ideal world, the coverage would attach to the patient and not the facility, it seems to me. And you would have a system in which the patient could go to a site of care and get the most appropriate care for that patient, whether that's methadone or buprenorphine or naltrexone. And so by expanding Medicaid, and there are a number of different state models sort of in use and being developed, and we heard about Vermont today, and I think there's a lot of interest from states in doing something like hub and spoke, although every state means something different when they say hub and spoke, which is actually sort of important to understand. But to have a setting where you have coordinated care in an accessible setting, and as a byproduct, if we're talking about, for example, Medicaid, if a state expands Medicaid and shifts some of that care that's being funded through a grant into Medicaid, then that frees up money that they can reprogram to put out into the state for other purposes.
So let me add a little color to that. Yeah, I agree with everything that Alan said. 2 things. One is, in a little bit of defense of the states, go into the Wayback Machine to, is this on? Yeah. Go into the Wayback Machine, think about what the world was like in 1970. If you think stigma is bad now, right, where it was stigma on steroids, in every way you could imagine, the science was far less well developed and it wasn't taken as seriously. And so it was any port in a storm. So they started funding any willing provider that was willing to take on the problems of these populations. And I think that helped. But the world has moved on. And I think that's the problem we're facing. And the money was given out to states because the states, as you know, are really, really, they're all over the map. They're very different. And I think we're at a point now where we can introduce more of the science of performance and knowing how to do things right to sort of up the game in that area. The good thing about Medicaid expansion is that to get Medicaid money now, you have to meet conditions of participation, which means you have to look more like a healthcare provider. And the data I showed you showed that if in fact you start to look more like a healthcare provider, you are much more likely to provide MAT and to have the medical and other backups that you need. And so in a sense, I think we're starting to lean in the right direction, but I think it's going to take a lot more push to get to where you want to be.
I think, absolutely, and I think, really having a vision of kind of where we want to go, as Alan mentioned, is really, really, really important. And that part of what we don't have is we don't have a system that recognizes that there's a primary care kind of general health world, and then there is the specialty world. And that thinking about kind of what HIV went and how HIV specialty clinics and the lessons learned there, how they got funded, how they got set up, the performance measures, I think actually we could learn a lot. Because one of the things that that I think about a lot is, in my practice, we treat hepatitis C. We provide all 3 FDA-approved medications. We treat people for their alcohol use disorder. I mean, we have an opiate treatment program, but it's not just opiate treatment. And people don't walk in with just opiate treatment. And so taking advantage of all the different settings in which people kind of get into care and helping make those settings attractive so that people actually want to go there and stay there, such that we can help with all of their various different needs, maybe not just by one provider, but having the funding mechanisms and the payment systems and then the performance measures to be able to actually demonstrate to people that, yes, in fact, your opiate use disorder is getting better at an individual level and at a population level. The second thing I would say is that it's not just about the funding. It's, it's all a regulatory issue as well, because the regulatory barriers that were set up, or the system that was set up in 1970 is outdated. And really thinking about, I have patients who are on methadone who have been on methadone for decades, who come once a month. There are states that will not reimburse for once a month care, even if they cover methadone treatment. Right? And so the financial incentives that align with a chronic disease, even in those areas where there are those financial supports, aren't necessarily aligned. And having performance measures that speak to a chronic illness is not something that we've historically had. I mean, historically, the national outcome measure systems were all in the NOMS. They were based on admission and discharge. Discharge in the world of a primary care physician, in the world of addiction medicine, doesn't make any sense. So I think that there are a lot of those also other types of things that we need to think about in terms of kind of regulations and performance measures.
Scott, then David, then Kathy, then Huda.
Thanks for bringing up the regulatory stuff. Working in an OTP for a long time, so I'm hip to that. But my question is for Dr. Frank. What are you using as your denominator? So you bring up the importance of we're not providing this to enough people, but how many people in the United States have opioid use disorder for those particular rates?
We don't really know. If you look at the study that came out this week from Massachusetts, and it's not the first, it's like 4 or 5 different efforts, the ability to identify opioid use disorder is, it's generally hard. It's especially hard when you go from prescription agents to illicit agents. And what's happening with the epidemic is it's going from the things that we're best at measuring to the things that we're worst at measuring and growing at the same time. And so if you look at like the NISDA data, it looks like, for example, misuse has been, it's been bouncing around, but it's more or less flat. Opioid use disorder, actually went down a little bit. That is so inconsistent with data from physicians' offices, from hospitals, from emergency rooms, et cetera, that we need to kind of start to rethink it. And then you get these studies like in Massachusetts that shows that we were off by a factor of 4 to 1. So we don't really know, and in fact, you're not going to be able to do what Alan proposed until you have those numbers. Kind of define where you're going to, what your target is.
David.
Thank you. So this goes back to your comment about grant money going to specific places. And I think you use the word established, or I'm not sure, instead of new ones, going to established. And so, Tom McClellan created this scorecard to help inform consumers. Are you thinking about something like that, or are you thinking about or have you thought about criteria going forward that grant money would go to?
Even though I think it's really, really important to equip consumers with more information, with more choices, with an idea of what they're receiving in terms of the quality, I'm pessimistic that that's going to drive the system enough by itself. And so I think you need to combine, so you want to do that, but you want to do that because you want to destigmatize, you want to show respect. There are a lot of reasons for doing that. But I think if you want to drive the system, you have to deal with some basic common sense performance measures and make sure you put money and incentives behind it. So in fact, if you don't do those things, you don't get paid, or don't get paid as much. And I think you need to do both. Yeah.
I agree with that, and I guess I would add that in addition to payment levers to improve quality, the state also has authorities around licensure and so on that they can use to shift towards higher quality. And then I think also there's a sort of recognition among payers and probably states too that they can't just cut off non-evidence-based treatment facilities without having somewhere else to refer patients to. So it has to be something that's signaled ahead of time and a sort of stepwise shift of dollars to higher quality care.
Mm-hmm. Yep.
So would you say organizations that don't provide medication-assisted treatment would be a deal killer?
Well, let's start with this. Organizations that exclude individuals who are on medication.
Yes.
He said, would you exclude providers that don't provide medication?
He said, or what?
And I said, start with excluding providers who exclude patients who are on medication, whether or not they provide it.
So my understanding is that Connecticut, many years ago, probably about 10 years ago, in their Medicaid program actually looked at people who had an opioid use disorder who had gone through particularly a kind of now what's called withdrawal management or detox types of care. And what they found was that there was a significant percentage of individuals who repeat that cycle multiple times over the course of the year. And that they decided that they would pay for, through their Medicaid program, they would pay for 2 cycles of kind of opioid detox. That by the 3rd cycle, if that happened within the same 12-month period, they would no longer pay for that cycle. Because the data, particularly for withdrawal management for medications, and I think that, and this may have been discussed earlier, but when we talk about medications for addiction treatment, we also have to be very clear about what it is that the models that we're talking about. So we're not talking about short-term tapers or kind of the old-fashioned detox. We're really talking about kind of people who need to take medications and exactly how long those medications they need to take. That probably was addressed in an earlier panel. But that essentially, so you're leaving open the ability for people to, yes, maybe they actually can, there are certain medications or models that they are looking for or that they're interested in, but that at some point, and as a primary care physician, if somebody comes to me and says, I want antibiotics for my viral infection, I am in a position where I have to say, there is no evidence for antibiotics for viral infections. I could actually be making you could then have side effects for which there really is there's no medical indication for this. So I think we really need to actually start looking at treatment of opiate use disorder with these medications in the same way, because the evidence is so clear that people die without them. I mean, we've heard about this, and that we have study after study after study that looks at withdrawal management, and people relapse. The relapse rates are over 95%. So I think that at some point, and I absolutely agree that that there are so many places in the country and in Maryland, even in my backyard, where I can't get my patients into because they say, nope, we won't take them for, they're on methadone, or they're on buprenorphine, or we will take them, but they have to taper down to 30 milligrams of methadone. And when I ask kind of on the basis of what, there's no medical rationale. It's an ideology of we don't think that this is good medicine.
Kathy?
I think I want to follow on that because I think Dr. Frank mentioned it too. That the persistence in the system of payment for non-evidence-based treatments. I mean, we were just talking about this. I mean, and this is something that bothers me. We spend billions on stupid stuff that doesn't work, and now we can argue kills people. I'm on a rant. And we can't, and we put people. Okay. What kind of leverage do we have in this country to move it? Because people really are dying.
I guess that's me. So I do think that the world is moving towards payments where there is risk, and the risk is in part tied to performance. And I think that making sure that we don't take substance use disorder exceptionalism on a path that steers you away from that. So you want to ride that train, and you want to become more part of it. I think that that's part of it, is mainstreaming substance abuse disorder treatment will do two things. It'll provide more treatment, and it'll probably provide better treatment. And I think, therefore, kind of pushing our institutions in that direction is an important thing to do. I do want to at least raise, I need a little therapy here, which is a problem that I have is that even though there's a lot of bad stuff or stuff that doesn't work being done, I think that to some extent, if the choice is no treatment or at least starting to get hold of, engage somebody, I think that's important. And so I guess my modification, my friendly amendment would be, don't pay people who disconnect themselves from medication-assisted treatment. They don't have to do it themselves, but they need to provide an on-ramp to getting that, because I think that you don't want to discourage engagement when you're treating 25% of the people out there.
I'm sorry. Okay. Can I add just three quick pieces, because I'm afraid I'll forget my train of thought because I'm ADD. So for the piece on stigma, right? Three biggest things that we run into is like for instance, Alcoholics Anonymous model, right? They believe in complete sobriety. That means absolutely no mind-altering drugs. So you have the stigma from that point of view, and then you have the misuse. And so even in our own recovery community, you have that, that belief within treatment centers or IOPs or extended recovery, like an Oxford House or whatever. Oxford House in particular will accept, people, but a lot of them won't. A lot of the homes won't, because what will happen is you have situations where other people may be using nothing, right? And they feel that their sobriety is at risk because someone else might be on these medications. What they're not understanding is it's less stigmatizing to go in and get a pain medicine prescription on a monthly basis. No one questions that. But when you need this other medicine, all of a sudden it's an issue because occasionally it's diverted. But they were using Kool-Aid. They were abusing Kool-Aid when I was in the jail. They were actually snorting Kool-Aid. So people who are going to do this are going to do it. And the other piece is when it comes to getting people the support for that. A lot of the you have a lot of these clinics that are out there, and for the recovery community and for their families, they believe that big pharma created the dilemma that we're in now. So they feel like this is just an extension of that. So there's a lot of hostility. And in the community, we find that there's a lot of these non-regulated, they have they get on a couple of prescribers into their facility, right? But they don't do everything else they're supposed to be doing, which would be like making sure that people are urine tested regularly, making sure that they're in recovery programs, making sure they're getting other supports. They don't do any of that. It's just a cash exchange, that's it. And sometimes you have issues where they'll have somebody come in who's maybe addicted to Xanax, right? And is given a prescription for Suboxone, which would be inappropriate at that point. Or someone that's coming in addicted to methamphetamine is given a prescription for Suboxone, and then you've created sort of a new problem. So,
Walter, then Huda, then Yasmin.
Yeah, first I should thank Dr. Volkov for putting the image of a bunny rabbit into my head. Okay, this is really for Dr. Frank, I guess. You mentioned venture capital and that it's obviously all private money. Most of the committee here are from non-for-profits. And I know that more than half of the methadone programs are private now, for-profit programs. And I don't know how the hookup is with the Data 2000 doctors, but I suggest a lot of them are for profit. Where does all this economic stuff fit in the for-profit world?
Well, I'm an economist, so I'm not knee-jerk for-profit. So but I do think there are incentives to cut corners, to stint on care if you're being paid up front for treating somebody, and that's what I worry about. I worry about it for both nonprofits and for-profits. So I think that's why, in a sense, economists are very cynical people, and so they think the worst of everybody. And so what that means is making sure that you measure performance carefully, that you link it to payment, that you monitor things, that you have a system of accountability. And if you do that well, I think both types of organizations can do a good job.
Can I just wanted to give one quick example, actually, of, so in Maryland, we had opioid treatment programs received a weekly bundled payment for all of their services, and it was supposed to include medication delivery, counseling, and all the medical services. A few years ago, Maryland actually rebundled their services because it became pretty clear that there was no way that the state had any idea what people were really receiving. There was no requirement for actually reporting on how many counseling sessions people were getting, how often they saw the physician. And it was pretty evident, we all knew that there were physicians who were coming into opioid treatment programs for 2 hours a week and just signing off treatment plans and signing orders. There was very little medical care that was happening. So the state actually decided that they were going to not completely unbundle things, but rebundle things. And now are looking at, this has been now year 2, it's pretty clear that people are getting more counseling services. Whether or not that's helping outcomes is still the issue, because we don't have those performance measures that then actually get tied to the reimbursement and kind of both incentives, positive incentives and negative disincentives. That's what we need next. But I would just mention that that's one of the issues, I think, related to some of these payment reforms, is that bundle payments in a lot of different places in medicine sound really great, but if there's no transparency as to actually what's happening within that bundle, and you don't have those performance measures, you can end up in incentivizing really the wrong thing.
I agree.
As I said earlier, I'm not a clinician in the front line, and so I'm just looking at, but I'm very interested and committed to this problem at many levels. And so I've been listening sort of with a slightly kind of higher altitude maybe. And what I'm struck with is how disjointed every single thing is. And it is really, I mean, everything at every level. Mm-hmm. And it is really disturbing, because this is this huge problem and people are dying by the hour. I mean, you know, I don't know how many, 100 or some people died since we started this morning. And yet we're like, everybody is playing in a corner by themselves under their own little guidelines and, you know, in suboptimal conditions. And I don't get the feeling that we have tactics but not major strategies. And the government is giving us money, you know, as a country, and we're supposed to think about this and help. As a committee, we're supposed to think about all of this and see if we can think in a constructive way. And so one thing that strikes me for this group is that we can either ride on the current medical system, which itself is bewildering to me personally, seems fragmented, very state-specific, the incentives and disincentives are weird and so on. But I could see that the advantage would be that this is an illness. We're making sure everybody thinks of it as an illness. So being in that mainstream of illnesses would make sense. The alternative would be to say there are all these legacy programs that make no sense. There are all these crazy mechanisms that don't make no sense. And this is a moment of crisis where the government is paying attention to us. And is this a moment where we should think differently? Go back to square one, as he said. Don't underestimate square one. So should we think differently about all of this? And even if it is at, say, one level, whether it's like community systems or reimbursement systems or something. So this is like my very, sorry, it's like very general, but I would really like your wisdom on this.
Far be it from me to discourage a grand vision of wholesale change, but I think that's hard. And I think sort of the big idea in healthcare for the past few years is the one that we've spent a lot of time on today, that Richard and Ingvild have talked about, which is let's make the providers accountable for outcomes and shift the money to the provider and incentivize coordinated care that we're paying for what we want. So I think that moving the system in that direction is not wholesale reform, but of a piece with sort of overall trends in how healthcare reimbursement is evolving.
Yeah, I would also say that, as I've been thinking about this for many years. And there are many different lessons I think that we can learn really kind of from, because this is a chronic disease, and really thinking about this kind of as a chronic illness, and how do we treat other chronic illnesses? How do we talk about other chronic illnesses? And I always come back to diabetes, heart failure, HIV, then, and with some of the caveats that that there are pieces of substance use disorders and kind of opioid use disorder that may be unique. It also strikes me that that absolutely the pieces of all this system are so unbelievably fragmented. And between hospitals and community providers and detention centers and jails and parole and probation and a whole host of other housing and all these various different pieces that people need in order to actually effectively manage and learn how to manage their own illnesses, that we've made we've kind of created these artificial boxes. And so maybe if we go back and step back and look at like, what would we actually want this system to look like? Do we want people to be able to walk into their primary care physician and say, these are my symptoms, this is where I'm, struggling, and have physicians and nurse practitioners and physician's assistants who at least have an ability to screen and diagnose and talk to people about, here are the different treatment options, this is what we know works, this is what we don't, this may have less evidence. Have specialists designated and identified, well-trained, competent specialists, and have systems that actually then connect all these various different dots. Have, whether it's at a hospital, inpatients, emergency departments, kind of the long list I think that, Alan also mentioned. But then have communities and looking at actually what people need at a community level. So in Baltimore City, in an urban setting, as in the Bronx, housing and the stability of housing, the availability of safe housing is, I have patients who they're hopping from friend to friend to friend to friend to friend because the recovery houses that exist don't take people on medications, or because someone got shot right outside of their door, and so they now really need to move. And so the opportunities for employment, and employment that actually recognizes that they have a substance use disorder or a behavioral health disorder. And there are people in different pockets locally that really are working on all these different things and figuring out how we can kind of, at a local level, because I've thought about how at the national level there's certain things that can be put into place, policies, principles, monies. But a lot of the provision of all these services and where people live and figure out how to live with these illnesses happens at the local level. And networks of care happen at the local level. And so thinking about kind of accountable communities and how do we hold communities accountable in public health, from public health perspectives, is where, to me, also kind of the healthcare and our individual healthcare systems need to really also adopt these public health lenses and looking at ways that communities can be held accountable as well.
You raise a very important point, and I just want to say three quick things. One is history has not been kind to building on exceptionalism. It's been very unkind. Second is, I think you're underestimating how revolutionary it is going to be to bring the addiction treatment system into the mainstream of American medicine. It will talk about knocking around institutions, it will dramatically change the shape of those institutions. And then the third thing is, this is a big, diverse country, and particularly when it comes to addictions, you know, the cultural norms, as we have been learning every day these last 2 years, are really important in the way people view their social institutions. And you got to, you know, and so there's a real temptation to engage in policy overreach that I think is dangerous.
I agree.
Can I just say we've got like
Yep.
5-ish minutes?
Yasmin, we have 5-ish minutes. Make it short.
I will be quick in my 2-ish minutes. And it goes to Katrina. I mean, the nightmare that you lived and live. You know, you talked about idealists down the road, and I agree, and the reality is today. In your experience and with a peer, you know, how do we help people, because this, from the judicial system is one of the biggest issues for treatment, obviously, payments and all of that goes hand in hand. But that bridge, what aspect of it, if we could think about ideal, it wasn't ideal necessarily for you, but if we could think about ideal, because it's one of the things that we're kind of charged to do, what would be an ideal thing that you would like to see enacted or would improve outcomes if the peers system is enacted earlier? I mean, I just don't know, since, you know, your experience is very valuable.
Yes. I appreciate that very much. And you're right about the still being difficult. I mean, it's hard. It's hard. I lose people all the time. And we had a girl that I'm working with now that is everything I've done, I've tried to do, still is not enough. But one thing I keep finding over and over again is when you mention peer navigation. I think that that is the bridge, because when I was first in the middle, when I realized that I had a problem, right, I went to my I went to my doctor, my general practitioner, and I expressed what was going on. And he said, I said, I think I'm addicted. And he said, I don't think so. That's very unlikely. It's very uncommon. This is back in 2009. And I was like, oh, well, maybe something's wrong with me. I do have a history of addiction in my family, and I automatically start with the shame, and that was the beginning of the end. But one thing I believe you mentioned, and I think it's very important, is I do think general practitioners, because a lot of folks that will be the starting place. But then there are a lot of people who it is street level, right? Because we're dealing with heroin now, and let's just be real. And so it's very hard to get people into services, and so even if we do everything we can, we've got all of these great, you know, mobile units, we've got everything we need, and everybody could just walk in and be able to get treatment you know, right away, you have to talk them into it. You have to have them ready. And so I think the peer navigation part and the community, it's a societal disease, right? Mm-hmm. And it's born from loneliness. For my case, it was born from loneliness. In my daughter's case, it was, she went from being a sheltered, overprotected child to, my son went to the Air Force, went to college, went to the Air Force, and her boyfriend he was with Lockheed Martin, went to England, and mom is in jail. Mm-hmm. And she didn't know how to deal with it. She was 20, but she was very immature 20. So that loss of connection, so community connection, which could start with the peer navigation, brings all that together. But communities need to be it's sort of Wild West out there right now. Folks are kind of doing, in some ways that's a good thing because it's entrepreneurial, in some ways it's very bad because there's folks that are doing things that are very self-serving. They're not doing it for the benefit of the public. And I'm not saying that they shouldn't have for-profit ideas out there. They should, because that might make competition and actual quality better. But I think connection, if churches, I don't care who it is that wants to get involved and do something, I think she should be included. And as Richard mentioned, every area, when you have government that's overreaching, every community is a little different. And they have needs specific to their community, right? And folks, they need to be met where they are. And I think that happens from a rehabilitation standpoint. What I do with every single one of my mentees is I inspire them and I tell them my story and I say, and you can do what I do. And then they can begin to work and they can have an income that they're proud of. And not everybody is qualified, right? And you need to vet your best, but inspire them to get involved as well because people are going to listen to people with lived experience. I think it's peer navigation, so.
Thank you, Katrina, for that final word, and thank you for the full panel. Oh, Tracy? Tracy, did I cut you off?
I had a very similar question, actually, but maybe taking from Katrina from your story, but moving to a larger, more incentivized bundled payment opportunity. And Richard, you mentioned that there really aren't good examples. The peer support recovery specialist kind of movement or ideas around that a number of states, including Rhode Island, have really pioneered, whether it's associated with the emergency department or any one place, but or the prison jail system. Is this an area where research and where maybe research and practice have to be occurring at the same time? Does it extend? I mean, I do research. I do respondent-driven sampling. I do targeted sampling and recruitment techniques to try and get people who are hard to reach to come and talk to me and tell me about all the things that are really hard in their lives, what their behaviors and attitudes and concerns are. But I have to work real hard, more so than just put a poster up and say, come and talk with me. And maybe, you know, I don't know if there are equivalents for incentivizing individuals to come and connect with care, treatment, or potentially harm reduction services as a even further upstream idea. But these bundled payment approaches that incentivize large structures to think way farther upstream. Is there anything to that we could work towards?
Well, I think that's the frontier. I think that's exactly. I don't think we're going to come anywhere near fixing this until we really start to do that.
I want to bring in sort of one more idea that I think connects with this. So there are a number of places that peers are being used and being paid, but for different things. And I think it would be useful to sort of better understand what are the models that are most effective, but also sort of a connected idea in a lot of places that aren't ready to move to a bundle, and where a bundle's still infeasible because the providers are under different roofs and they're not ready to sort of assume risk. They're funding care coordination, which is sort of not a bundle, but achieves some of the things you're trying to get with a bundle, which is you have somebody who has an ongoing attachment to that patient and lines of sight into all of the aspects of care and the social determinants and the sort of environmental aspects.
I think George Mason, the research model I think that's because it's basically rapid quality improvement as we go. So I think that is the idea, is to have us navigating to health and have us all working together and secret. But you know, we're just started. It's new research, so yeah, definitely. Thank you.
Thank you to the panel.
Thank you.